A warm welcome to this webinar and podcast where we together review the new data that were presented at the ESGO Congress in Istanbul. I am delighted to have two fantastic faculty members and close friends with me today, Professor Mansoor Mirza from Rick's Hospital in Copenhagen. He is medical oncologist and vice president of the ESGO, and Professor Sandro Pignata from the Istituto Nazionale Tumori in Napoli, Italy, a key opinion leader in endometrial cancer, past president of the ENGOT. Wonderful to have you here. My name is Nicole Concin. I'm gynae oncologist located at the Medical University of Innsbruck, and it's my particular pleasure to report on the Congress outcome as ESGO president. We will today target three main topics of new data presented. First, the molecular characterization of endometrial cancer. Second, the efficacy and safety data in advanced and recurrent endometrial cancer with focus on immunotherapies. And third, efficacy and safety in advanced and recurrent endometrial cancer, focusing on other emerging agents. So let's dive deep into the molecular classification of endometrial cancer. The TCGA, the Cancer Genome Atlas, is now celebrating its 10-year anniversary in endometrial cancer. These data have completely changed our view on endometrial cancer, which gave this disease the name Cinderella disease. It's really four different distinct molecular diseases. All European major guidelines, the ESGO, the ESTRO, and the ESP, and also the ESMO guidelines have integrated molecular characterization into risk group stratification and treatment recommendations. And also the new 2023 FIGO staging system is now integrating molecular markers. I'll start with the data presented by Livia Xindoli from the European Institute of Oncology in Milan. They have shown data on the impact of molecular classes on oncologic outcome in a prospective trial from one tertiary referral center. What did they do? They have continuously done molecular classification in all incoming endometrial cancer patients starting from April 2019. They have done POL-E-MUTE analysis with next generation sequencing, dMMR status and P53 status determined by immunohistochemistry, and also RT-PCR for microsatellite instability status. They have compared the molecular subtypes with clinical pathological characteristics and survival analysis. And this was the outcome of this interesting data. You see here the distribution of molecular classification in this prospective cohort. NSMP, the highest prevalence, dMMR around 1/3 of patients, 15% P53 abnormalities, and a relatively high percentage of POL-E-MUTE patients present in this prospective cohort of stage 1 to stage 3 disease. Recurrence occurred in about 12% of patients. There was no recurrence accounted in the POL-E mutated molecular subgroup, and the highest recurrence rate in the P53 abnormal group. This is expected, and this reflects also what we see in the literature. POL-E has a protective role, and P53 abnormalities are a negative predictive value for outcome of our patients. So we move forward to the next abstract of Valentina Bruno. She did an interesting study examining new omic immunological predictive features and looking for the added value if this is integrated into parameters of existing guidelines to more accurately predict risk for recurrence in endometrial cancer patients. This group has studied the relative abundance of 5 main immune populations in public data and generated a machine learning-based model for disease-free survival probability prediction. In this EC framework, the model integrating the immune populations had a higher accuracy to predict recurrence compared to guideline parameters alone. And this opens up precision oncology approaches in terms of prognosis and decision-making for treatment and follow-up. Another interesting abstract of Dr. Pan evaluated the mRNA expression levels of immune checkpoint genes like PD-1, PD-L1, and interferon gamma in endometrial carcinoma tissue and correlated these findings with outcome of the patients. They had control tissue of 25 non-malignant tissues, and also in a subgroup of 81 patients, they have determined the 4 molecular subtypes and grouped them into hot tumors if a POLE mutation or dMMR status was present, and into cold tumors in case of p53 abnormality and non-specific molecular profile. And this interesting study showed that PD-1 mRNA expression was 7-fold higher in endometrial carcinoma tissue compared to normal. The same was true for PD-L1 expression, higher levels 3-fold greater in carcinoma compared to normal tissue, and also a strong increase of interferon gamma RNA expression 5-fold higher in the carcinoma compared to normal tissue. The correlations with clinical outcomes showed that a high expression mRNA expression of PD-1, PD-L1, and interferon gamma was associated with better clinical outcomes. High expression of PD-1 was predictive for relapse-free survival. High expression of PD-L1 was associated with better overall survival. And the hot tumors showed the highest expression of PD-1 and interferon gamma. So immune checkpoint molecules were shown in this specific nice but small study to be associated with clinical outcome in endometrial cancer patients. The last study on molecular classification we are going to discuss today is the data shown by Richard Schwammeis on the verification of the prognostic precision of the new 2023 FIGO staging system in endometrial cancer patient, an international pooled analysis of 3 ESGO accredited centers. This is a retrospective study that was performed at Gemelli Clinic Rome, Medical Universities of Innsbruck and Vienna, and where a total of 519 endometrial carcinomas were reclassified according to 2023 new FIGO staging and compared to the 2009 FIGO staging. Stage shifts have been analyzed and 5-year progression-free and overall survival rates have been calculated. And this is the main results in early stage disease. You see here only stage 1, stage 2 disease, stage shifts compared to 2009. occurred in 2023 FIGO staging in more than 1/4 of patients, so a substantial proportion. Importantly, the main shifts were upshifts to a higher stage, 90% upshifts, due to aggressive histological subtype and P53 abnormalities and substantial LVSI. Downshifts occurred in early stage disease in about 10% of patients, and they all concerned the presence of Pol E mutations. What you nicely see here is that Pol E mute carcinoma demonstrated the best progression-free survival, 100% 5-year progression-free survival rate on the top of early stage disease, and the worst prognosis at the bottom, the P53 abnormal. You see the new FIGO staging beautifully spreads the survival rates within early stage disease and adds additional granularity. We applied multiple statistical tests to compare the prognostic decision of these two FIGO classification systems, and all the tests demonstrated the same superiority of 2023 FIGO staging to predict progression-free survival and overall survival. So, to conclude, it is important to perform molecular classification in patients with endometrial carcinoma, and this is recommended by all major European guidelines. This will improve risk group stratification and guide clinical decision-making. Immune checkpoint molecules might be associated with clinical outcomes. This is new data that we have seen on PD-L1, PD-1, and interferon gamma expression, and I look forward to discuss this data. The new FIGO 2003 staging system demonstrated a higher prognostic precision compared to the old FIGO staging system. I would like now to open the discussion with Professor Mirza and Professor Pignata. So, dear Mansoor and dear Sandro, how do you interpret the data with respect to molecular classification, what we have seen at ESGO Congress? What is the importance of the new data we've seen?
I think these are very interesting and important data that have been presented. The message I understand from this abstract is that we absolutely need to use the molecular classification in our practice, because it may change our adjuvant therapy decision in many patients. And so we need to convince all the hospitals of our countries to do this. Of course, for some of these analyses, particularly the poly mutation, there are also organizational aspects that should be focused, and centralization of tests may be necessary in some areas. But I think it's worthwhile because you see that the prognosis change completely if there is a poly mutation, and our decision accordingly.
And I completely agree, Sandro. I think we are also learning something very different from the new data coming in the classification and how it correlates to that we have targeted agents which will take the subgroup of a population, and that population will benefit. That probably we have to start thinking of treatment algorithms not according to the stage of the disease, stage 1, stage 2, stage 3 relapse, but longitudinally, that we say that MMR deficient, how these patients should be treated in future in first line, second line, third line, the HER2, the P53 wild type. So I think our way of thinking should change from these horizontal stages in our mind to the longitudinal, to use that molecular classification much more practically in the clinic. What do you say? I would like to hear your comments on that. That may be quite provocative, but I think we have to go there.
Yes, fully agree. And I think we learned in ovarian cancer after many, many years that what we call ovarian cancer is not a single disease. And I strongly believe that this is also the case of endometrial cancer, where molecular abnormalities characterize different diseases with different behavior and, as you say, different algorithms of treatment.
I think this is really important, what you now stressed and suggested, Mansoor. It is really different tumors, these 4 molecular subtypes of endometrial cancer. And this is also the reason why the FIGO committee has actually taken the decision to record in all stages the molecular subtype if this information is available. So if it is available, this should be recorded. And because as you and Sandro beautifully pointed out, this will influence our treatment decision-making beyond a better prediction of prognosis. It has therapeutic implications. So if it's available, we need to know and we need to record it. And the 2 cases of polymute and P53 abnormality change FIGO stage, and already our existing guidelines do have treatment recommendations in these specific patient population. And it will become probably what is your consideration if we go in this direction? Probably we can be much more specific in our recommendations. What are your thoughts on that?
We know clearly now for at least 3 classes that we can probably change our behavior in for sure in the adjuvant setting. There is still 1 class where probably much more work is needed to better characterize, because it's still an heterogeneous group of patients without P53 abnormality, without DMMR, and without poly. And in this group, probably there are, again, different, completely different diseases that we need to try to identify.
No, I completely agree. I think that's why I call that group Jurassic Park. It's so heterogeneous. I think we are getting there. I think we are getting there. We are doing trials now. We will be starting the trials against HER2 separately. We will discuss, Nicole, later, the trials on the P53 wild type population. We will be doing trials with PARP, where you can say that P53 abnormal is a surrogate factor. So I think we are already moving to the right direction, taking these subgroups, finding the right targeted therapy, and doing the trials. My question is, can we now be mature to think in longitudinally what happens when this patient progresses? What are we going to do with that subgroup and that subgroup? So I think we have to start making our minds clear that these are, as Nicole nicely said, different diseases, subset of the different, that we have to look at each of these molecular type separately as much as possible.
And we will do so in the updating process of ESGO, ESTRO-ESP, endometrial cancer guidelines, which just started to include all this new evidence and to refer to the new FIGO staging. So the kickoff we did at the ESGO Congress, and we will be more specific in our recommendations, I guess. Just please, Mansoor and Sandro, if you share your thoughts. A nice piece of data we've seen is the RNA expression levels of PD-1, PD-L1, interferon gamma to correlate in this small but nice study with patient outcome. And also you saw the study using artificial intelligence suggestions for clustering 4 immunological subtypes, which goes in the same direction. And the integration of these immunological subtypes help to improve prognostication of the patients. What do you think about such approaches? I have not seen a lot of data on this before. Do you think that's an interesting piece to further explore, or what are your thoughts on this?
This is a very interesting hypothesis. It has to be validated in the prospective trials, which we have done. We have possibility to validate that, because we should be very careful. Right now, we know that immune therapy predictive value of which biomarkers is there for immune therapy's efficacy, that is MMR status, and that is TMB. PD-L1 is not the right predictive value. So combining it with others, and it would be nice. We also had some small studies telling us that different patients in MMR status could behave, if it is mutation or others, could behave differently on immune therapy. That was a retrospective data on small trials. We are just beginning to understand what is predictive and how we can use it. And we have to validate these data before we can use them in clinic.
Fully agree with you. The validation in prospective trials is crucial.
Regarding PD-L1 and personally, of course, I agree that it needs validation and further studies. Personally, I think PD-1, PD-L1 is a more dynamic process than the genomic landscape. So it's not easy to catch the real meaning of this expression level from the RNA. But of course, we'll see next studies. Regarding machine learning, I strongly believe that this is the future. The main problem is how to work on this. But we now start to see experiments done on genomic data, but even on morphology data. For example, the simple morphology in hematoxylin eosin can be used to develop machine learning process that can identify the subtypes. I think this is the future for sure.
Thank you very much for this wonderful discussion. We will now move on to the second topic, the emerging therapies for advanced and recurrent endometrial cancer with focus on immune therapy. We have seen amazing randomized phase 3 data on immune therapy recently, both published in New England Journal of Medicine, the RUBY trial, and also the NRG-GY018 trial. And at ESGO Istanbul Congress, nice further analysis of RUBY trial have been shown, namely the twist analysis and also a closer look at the safety profile in this trial. And we have also seen the data on an antibody drug conjugate targeting HER2 and the preliminary safety and efficacy data of this compound. And we will now dive first into this HER2 targeting ADC data. The compound is called DB1303, and it is the data on preliminary efficacy and safety in an ongoing phase 1/2A trial in different solid tumors. And for the first time at ESGO Istanbul Congress, the initial data in the endometrial cancer cohort have been shown, which currently consists of 32 endometrial cancer patients who were dosed with these compounds on 7 and 8 milligrams per kilogram IV every 3 weeks. the antibody drug conjugate, the payload of this HER2 targeting ADC is topoisomerase 1 inhibitor. In the endometrial carcinoma patients, the histologies included serous endometrial carcinoma, adenocarcinoma, and also carcinosarcoma. We know that carcinosarcoma and serous tumors in endometrial cancer particularly are the ones that harbor p53 abnormalities, and the ones who express HER2 measured by immunohistochemistry 1, 2, or 3+, or also by in situ hybridization positive for HER2 were included in this trial. The median treatment duration was 2.6 months, and 90% of the patients remained on treatment. And we will see now the data on the objective response rates, which was the primary endpoint, together with safety, namely equal or bigger grade 3 treatment emergent adverse events. And for the objective response rate, that 17 patients were evaluable for response. And of these 17 patients, we saw responses in 10 patients. 2 of 4 patients dosed at 7 milligrams, and 8 of 13 patients dosed on 8 milligram. So showing a 50% and 60% objective response rate at 7 or 8 milligram per kilogram respectively. The disease control rate with this compound was impressive with 94%. Regarding the most common treatment emergent adverse events we've seen is vomiting, fatigue, and nausea. And adverse events grade 3 equal or greater grade 3 were syncope, anemia, and hypokalemia. There was no occurrence of interstitial lung disease, and also no drug discontinuation or death due to treatment emergent adverse events. For the RUBY trial, we've seen 2 interesting new pieces of data. I'll start with the Q-TWIST data. What is Q-TWIST? This is the quality-adjusted time without symptoms of disease or toxicity. We all remember the RUBY trial. It is a phase 3 trial in advanced and first recurrent endometrial carcinoma patients, where chemotherapy plus dostarlimab and maintenance treatment with dostarlimab was compared to chemotherapy alone. This quality-adjusted survival was calculated based on the safety population as the sum product of mean survival time in 3 mutually exclusive states, and one of these states was time without symptoms of progression or toxicity, the TWIST. And these data I will show you now for the overall population, for the dMMR population, and for the pMMR population. The median TWIST was significantly higher in the overall population, in the dMMR population, and in the pMMR population, with differences of 4.4, 5.4, and 2.6 months respectively, comparing dostarlimab plus chemotherapy versus pure chemotherapy. Thus, the addition of dostarlimab significantly improved quality-adjusted survival in each of the 3 populations examined. We also saw the safety data in detail now in the RUBY trial. Another nice piece of data presented at ESGO Istanbul Congress. We have seen the data of the safety population of a total of 487 patients. The treatment emergent adverse event equal or bigger than 3, about 10% higher rate in the dostarlimab plus chemo arm compared to the chemo alone arm. The discontinuation rate of dostarlimab or placebo due to treatment emergent adverse events was 17 versus 9% approximately in the combination arm versus chemo alone. Importantly, the completion of chemotherapy was the same rate in both arms. Thus, the addition of dostarlimab to chemotherapy did not compromise the completion of the chemotherapy treatment in the RUBY trial. If we look at immune-related adverse events, of course, as expected, in the combination arm, chemo plus dostarlimab, higher than in the chemotherapy alone arm. Here we see the prevalence of treatment emergent adverse events. The most common ones in either arms were fatigue, alopecia, and nausea. If we look at equal, greater than 3 treatment emergent adverse events, the most common ones, more than 10%, were anemia and neutrophil count reduction. There were 5 deaths reported in the dostarlimab arm. 2 of them were deemed related to dostarlimab and 3 were not related to study treatment. So in conclusion, we've seen first promising activity and safety data from the compound DB1303, an ADC targeting HER2. And from the RUBY trial, we have seen beautiful new data showing significantly longer quality-adjusted time without symptoms of disease and toxicity in the combination arm of chemotherapy plus dostarlimab compared to chemotherapy alone. The safety profile of dostarlimab and chemotherapy was consistent with that of the individual components. The most common treatment emergent adverse events occurred more frequently during the chemotherapy, and importantly, the addition of dostarlimab did not compromise the completion rate of chemotherapy. I would now like to open the discussion to our panel.
If I may start with the ADCs against HER2, targeting the HER2, I think this is an amazing time. We saw at ASCO this year the data on Destiny trial, on the TDXD, the patients who had HER2 3+, the response rates were 87% and above 60% for the HER2 2 positive. And this, the new ADC by BioNTech is again confirming the same. I think I would have wished that we had more data available on 1+, because I believe 1+ could be another bigger population, because 2+ and 3+ are about 20-25% of the population. If we had 1+, we could have had 40% of the population. But the validation of the biomarker for 1+ is still ongoing, and we may not have for endometrial cancer a 1+ biomarker until end of next year. So the phase 3 trials are now starting for 2+ and 3+. And I'm sure that this will be another giant leap. We will see the results in coming years. Definitely, this is going to change our standard of care. Sandro, what do you think?
Well, two points. First is that antibodies, drug conjugates, are completely changing the scenario in many oncology diseases. So it's not just data in gynecological cancer, where we also have seen recently important data coming, but in every disease. So it's the concept of targeting with the antibody that is working very well. And regarding the data presented at ESGO, I have to say that this follows our previous discussion. So we have now some new drugs targeting specific population of endometrial cancer. So this concept is valid in the early endometrial cancer, but in the future we will have more data in the metastatic setting, where one dress probably doesn't treat everyone, but we need more specifically target and new drugs for the treatment of our patients.
And on top of that, I think we are starting learning how to manage the toxicity of these drugs. We had initially quite a lot of ILD, and I think that we have moved to a phase where we are really trying to tackle all these things and keeping the efficacy.
Yeah, it's a really interesting concept to deliver the cytotoxic payload specifically to the cancer cell by targeting proteins on their surface that are specific to cancer. So this HER2 approach seems very promising, as you said. Mansoor, will it be mainly the p53 abnormal, thinking about molecular categories again? Can you elaborate a bit on that?
Exactly. So this is a subgroup of patients who are p53 abnormal, 2+ and 3+. And basically what we are seeing is this is actually, before we started targeted therapy, one of the worst groups, right? If you look at the early data, what we have seen. So we are really targeting that worst group and in changing it to completely different status, what we are doing. This 2+ and 3+ will be consisting, if you take histological types, mainly serous adenocarcinoma and some carcinosarcomas. So these are the patients with real unmet need, and we are going to completely change the outcome of these patients. I'm very sure about that.
Wonderful. The quality of life data that we have seen now in the Ruby trial, I think this is really important data to look. I mean, what we would like to see in our patients is, of course, improved survival as the hard endpoint, but at the same time, improved quality of life. This is really what we wish from a treatment. Do you have considerations on these data?
Yeah, sure. I think this is very important. Of course, the trial was randomized, so it was a comparison against placebo. But in the practice, we are comparing a maintenance therapy, chemotherapy, with the maintenance compared to observation. So the fact that this maintenance that does not impair the quality of life, and that the symptoms are not so strong in impairing the life of the patient, is very important, because the quantity data are fantastic particularly in the dMMR population, and so these additional data presented at ESGO, I think, are very reassuring us on the patient point of view, because the symptoms are manageable, and many of the symptoms we have seen are in the chemotherapy phase and are related to chemotherapy.
I feel that we are privileged. We are privileged because we have worked hard to design these new trials, and we believed in these trials that they will change the outcome of our patients. And we are seeing these results, these magnificent results in our lifetime. So that's the great feeling we all have. We are part of it, all of us, that we are improving. We are considerably improving the outcome of our patients regarding efficacy. If you look at the Kaplan-Meier curves, especially in the DMMR population, you would see also in the overall survival, in the PFS after 12 months, they're just flattened at 60%. So we probably are curing some of these patients, and the same is the case for overall survival. Toxicity profile is quite balanced and manageable. And on top of that we improved the patient-reported outcomes. You saw the Q-twist data today. So it's a win-win situation. We are completely changing the course of this disease. And as you said, Nicole, this is a true Cinderella story.
These are some really important points that you've made here, particularly what Sandro said. I mean, we are adding a maintenance treatment to patients with advanced stage and recurrent disease. So how wonderful it is to see that this does not impair, opposite is true, the quality of life of the patient. So these are really important data that we've seen here. And it's wonderful to see the overall process. And we're really lucky to be there in that time where individualized treatment per molecular group is becoming the reality. Do you have considerations on the safety data that we've seen in RUBY trial?
I think most of the oncologists, gynecologists involved in endometrial cancer, but I have probably as a medical oncology a larger view. Also in other diseases. I think we learned that a single agent immunotherapy, even if combined with chemotherapy, have a good safety profile. We are now, there is a training course, of course, in identifying and treating the immune-related side effects, but everything is feasible. And the balance between the positive effect and the negative effect related to the side effect is totally in favor of the treatment.
Thank you very much for sharing these important thoughts and for discussion. We move on to the next topic, which is other emerging agents in advanced and recurrent endometrial cancer. And we have seen some nice new pieces of data at ESGO Istanbul Congress. A lot is going on molecularly targeted treatments, and very interesting data we've seen in P53 wild-type endometrial carcinoma with 2 drugs, selinexor, and 1 trial ongoing now with naftemadlin. And we'll have a little bit a closer look on these trials. So let's start with the nice presentation of Alexandro Fidalgo on the long-term follow-up of selexinor maintenance for patients with P53 wild-type advanced or recurrent endometrial cancer. This was a pre-specified subgroup analysis of the phase 3 SIENDO trial, ENGOT-EN5 and GOG 3055 trial. So what kind of trial was this? The SIENDO trial is a randomized phase 3 trial that includes stage 4 endometrial carcinoma patients or first recurrent patients. They receive chemotherapy And when they respond to chemotherapy, they have been randomized to either receive maintenance treatment with selinexor or no maintenance treatment, placebo. What is selinexor? Selinexor is an XPO1 inhibitor. This is a nuclear export inhibitor. And by inhibiting nuclear export, many wild-type tumor suppressor genes, such as p53, is kept in the nucleus. So it keeps the pro-apoptotic wild-type tumor suppressor gene in the nucleus. We have now presented at ESGO Istanbul Congress the long-term follow-up data of this trial with a median follow-up of more than 20 months. And this is the beautiful results in the p53 wild-type group. You see that the addition of selinexor during maintenance treatment has significantly improved PFS in p53 wild-type patients. What about the adverse events with this drug? The most common adverse events include nausea, vomiting, diarrhea. Most common equal or bigger grade 3 adverse events are neutropenia, nausea, thrombocytopenia. This successful concept of the SIENDO trial applying selinexor in the maintenance treatment in advanced and recurrent endometrial carcinoma patients is now further advanced to a globally enrolling phase 3 trial, the ENGOT-EN20 trial, which includes now only the specific group of patients with p53 wild type endometrial carcinoma. And after response to chemotherapy, they are again randomized to receive maintenance treatment with selinexor or placebo. And we eagerly await the results of this trial. Now we move on to another compound which works in a similar direction as selinexor. The drug is naftamadlin. Naftamadlin is an MDM2 inhibitor, and MDM2 is the key negative regulator of p53. So by inhibiting MDM2, you will also increase pro-apoptotic p53 wild-type levels in the cancer cell. What is the design of the trial, which is an ENGOT and GOG trial, ENGOT-EN21, GOG-3089. This trial is in advanced stage 4 and first recurrent endometrial carcinoma patients. The patients receive chemotherapy up to 6 cycles, and in case of complete or partial response to chemotherapy, the patients will receive in the part 1 of the study naftamadlin maintenance treatment at 2 different dose levels that are explored, 180 milligrams or 240 milligrams every day. It's an oral drug, day 1 to day 7 in a 4 weeks cycle. And there is one arm as a control where no maintenance treatment is provided. This is part 1, a phase 2 trial is the part 1 to explore the dose with the primary endpoint of recommended phase 3 dose. And then there follows the part 2, which is a phase 3 trial where finally the randomization will take place for either maintenance treatment with naftamadlin at the dose determined in the part 1 or no maintenance treatment, placebo. So to conclude, the selinexor maintenance treatment has shown durable progression-free survival and significant increased progression-free survival in the p53 wild-type endometrial carcinoma population. And there is another trial ongoing with naftemadlin, MDM2 inhibitor, that also restores p53-mediated apoptosis in p53 wild-type tumors. And we look forward to seeing the first results of this trial. I would like to open the discussion now with Professor Mirza and Professor Pignata on these interesting data that we have seen. What is your interpretation, or what are your considerations on these p53 wild-type approaches?
Well, my first thought is that these are extraordinary times, because this is the type of new modern trial that we will see more and more in the future. Here we are targeting a specific population, the patients with p53 wild type. Previously, we have seen a population with p53 abnormal. So this is what we want to do for the future, to have data in all these populations. Of course, these are preliminary data, but the phase 3 are ongoing, and we will see soon the results. And these promise to, again, modify the algorithm of treatment for our patients.
Yeah, and I completely agree, especially when we'll have the more granulation on the results of the immune checkpoint inhibitor trials. We probably will see that the patients who are p53 wild type and so-called cold tumors, MMR proficient, NSMP, these are the patients who benefit least from immune checkpoint inhibitors. And this will be, again, an unmet need. And there, the ENGOT-EN5 SIENDO trial has shown in the subgroup analysis an unprecedented increase. The new analysis, the longer time analysis, showed actually PFS increased from 5 months to 27 months in the median, which is really amazing. And if that, because it was the subgroup analysis, study was not powered to that, so one has to do the confirmatory trial. And then that's different mechanism with naftemadlin. So I think these two trials are going to change our standard of care once again in that subgroup of patients, which is really great. As Sandro said, we are living in a great time.
This is really wonderful perspective for our patients, right? So yeah. I was very happy to listen to you, Mansoor, now mentioning the NSMP, non-specific molecular profile. Because we always talk about p53 wild type with this drug. Can we add, please, can you explain, can you add a bit more granularity to this p53 wild type? What molecular subtypes does p53 wild type comprise? And for which of these molecular subtypes do you think that these drugs are of particular interest?
Yeah, I think that's a great question. So what is p53 wild type population? Basically, most of these patients are endometrioid adenocarcinoma grade 1 and 2. 1/3 of p53 wild type are also MMR deficient. So there you have immune therapy, which is doing a great job. About 90% of these patients are estrogen receptor positive. So there we would probably will see addition of CDK4/6 inhibitors to endocrine therapy to see if we can benefit them more. And then you have the left 2/3 of the population of p53 wild type, which is NSMP, which is MMR proficient. And that population is in a real unmet need. And I believe that we will see these drugs are doing miracles in whole P53 wild type population, including those who are DMMR. But for DMMR, we already have a very effective treatment available. But when it comes to MMRP subtype, I think we are going to really change their outcome by these two drugs.
Thanks. I think this is really important to stress, right? So the wild type is everything what is not mutant, what is not P53 mutant is wild type. So, and as you nicely said, the DMMR within the wild type, we have amazing results of immune therapy that will probably be very, very difficult to beat. But the proficient wild type, which is actually the NSMP, this is we really have a high unmet need in this patient population. And now there comes the drugs. It's wonderful news. Sandro, do you have considerations on this?
Yes, I think this is a very interesting population because in the patients that are not DMMR and are P53 wild type, there are several different mutations, for example, that are today targetable. Think about PI3 kinase inhibitors, think to new endocrine therapies. And probably in some cases, we could combine treatments. Of course, it will be difficult to design the studies because if we do subgroups of subgroups, it will be difficult to enroll, but this is the task for ESGO.
Do you have more considerations on the NSMP or on other potential emerging drugs besides what we've now discussed?
As Sandro has already mentioned, the big 3CA, we are trying to put up trials with the drugs which are hitting the mTOR, big 3CA pathways. We are trying to develop the drugs with estrogen receptor positive disease with CDK4/6 inhibitors combination. So there are many other things happening which will be adding to it. Another thing we still need, which is we haven't reached there, is in the same population of so-called MMR NSMP, the MMRP wild type. There is a small subgroup of patients who have a very high tumor mutational burden, and we have to figure out how we have a validated test to find that, because these patients will again have benefit from immune checkpoint inhibitors more than anything else. So I think we have to further divide this subgroup into smaller and smaller population, but I'm sure that we can do trials in these subsets and show benefit for our patients.
So the 4 molecular subtypes are not the end of the story.
It's just the tip of the iceberg.
The tip of the iceberg. It's just beginning. We will have more granularity within the molecular subtypes, and we're there to design the right trials for the right patient population. This is a big challenge, and I think with all the new opportunities and evidence, also a big excitement and good news for our patients.
I would again like to insist that we stop thinking about first line, second line, the first disease, then the relapsed disease, and this. We should go the other way around. As I said, if we look at the MMRD population as separate and see what we do after progression and so on, take the other population of HER2 and so on. We have to rethink in our mind how we look at this disease, how we're going to treat this disease.
Fully agree. Sandro, do you have summarizing final words?
No, I also agree. What I can say is that all this information will be useful also for the patients that will recur after immunotherapy. because also DMMR patients have some other abnormalities that can give us the opportunity to treat specifically in the recurrent. So it's really an evolving landscape, that of endometrial cancer.
So it's important to know these molecular characteristics at diagnosis and at relapse. I want to thank this wonderful faculty. Mansoor, Sandro, thank you very much for sharing your important considerations and for joining this discussion. And I want to thank the audience for watching this webcast and this podcast. And I hope you enjoyed reviewing the latest data of ESGO Congress in Istanbul 23 with us. I hope to see you soon. Bye.
Thank you, everyone.
Bye. Thank you.
Thank you.